Good afternoon, and welcome to today's presentation, Implementing Evidence-Based Guidelines from Education to Execution. My name is Valencia Harper, and I will be your facilitator today. At this time, all attendee lines are muted for this session to minimize background noise and distractions. We encourage your questions and input throughout this presentation, so please feel free to use the raise hand icon in your taskbar, or you can submit questions and comments in the chat box provided. Today's presentation will also include polling questions. We encourage everyone to participate as we value your interaction. Today's presentation will also be recorded and later uploaded to our HealthVisions Delmarva PTN YouTube channel. You may find the link on the flyer included in the invite to today's webinar. Today we are privileged to have Cindy Eiseman as our presenter. Cindy Eiseman is the Project Manager for HealthVisions Delmarva, a practice transformation network working through the CMS Transforming Clinical Practice Initiative. Cindy has over 30 years of experience in healthcare, starting in the area of health information management and expanding her skills in areas of expertise to performance improvement, operations management, healthcare financing, and practice transformation. Cindy has been a CEO, COO, and Regional Quality and Operations Director with Health South, Kendrick, and several community hospitals. Cindy is a native of Pittsburgh and graduate of the University of Pittsburgh and the Troy University in Alabama. I would now like to hand it over to Cindy to begin our webinar.
Thank you, Valencia. I really appreciate it. Appreciate everybody who could join us today. We have a very important topic to talk about today, and that's evidence-based guidelines. And it's important because it's something that's going to help us to drive improvement in your individual practices and for our PTN as a whole, and then rolling right on up to TCPI. So for today, our questions to run on are the following. Why are evidence-based guidelines needed to improve health outcomes for our patients and patient populations? Where can evidence-based guidelines be sourced or found? How can the PDSA methodology be used to implement evidence-based guidelines? And how can I hardwire the use of guidelines in everyday practice for consistency of results? And I also added there a quote to think about as part of our questions to run on today. And that is that education is not the learning of facts, but the training of the mind to think. And I think that that's an important thing to keep in mind. When we talk about evidence-based guidelines, we aren't talking about just one way of doing things. We're talking about exactly guidelines, things that can help to guide us in our decision making and in our care planning, but that require that clinical expertise, thought, and input from all involved to get to the right care plan. So Valencia, why don't we start with our first polling question?
Certainly. And it reads, my practice has implemented evidence-based guidelines and follows them consistently, has educated on evidence-based guidelines but does not follow consistently, and does not use formal evidence-based guidelines. So we have about 40% that's voted so far, still collecting responses, and we're in at about 70%. It looks as though 29% have implemented evidence-based guidelines and follows them consistently. 44%, well now we're in at 90%, so 22% has implemented evidence-based guidelines and follows them consistently. 44% has educated on evidence guidelines but does not follow them consistently, and 33% does not use formal evidence-based guidelines.
Well, that's pretty equal distribution, I would say, relatively speaking. Happy to see that the vast majority have identified evidence-based guidelines for use. And so a lot of what we're going to talk about today is how we can take those things that you've already identified as important to your practice and use the PDSA model to implement them. So first of all, I want to talk a little bit about the basics. What are evidence-based guidelines? Evidence-based practice is defined as the integration of clinical expertise, patient values, and the best research evidence into the decision-making process for patient care. It's not a cookbook, it's a framework. It's a framework for decision making that's based on the combination of sound clinical research, input, and provider expertise. And that's what our graphic shows. You know, our decision making in creating care plans really needs to include these three elements if we want to have care plans that are effective. So the evidence-based guidelines serve as the framework, but we need the clinical expertise of the provider, and we need to consider the values, needs, and preferences of the patient if we want to create an individualized care plan that really meets that patient's needs and really achieves the outcomes we're looking for. So what's the case for using evidence-based guidelines? We looked at some information from the Agency for Healthcare Research and Quality, and their research showed several types of quality problems that occur when we don't use evidence-based guidelines. And the first and kind of overarching one is variation. There's a wide pattern of variation in healthcare practice. Regional variations, small area variations, variations within practices when we aren't kind of following the same kind of playbook. One of the results of that is underuse, which is not receiving care. So, for example, a study of Medicare patients who suffered heart attacks found that only 21% of eligible patients received beta blockers. The mortality rate among patients who received beta blockers was 43% lower than the non-recipients. So if we had more, we had less variation there, and we had more patients who were eligible using those drugs, it looks like we could positively improve the mortality rate. So underuse could be one issue. Overuse is another issue, receiving healthcare services that are not necessary. An example of that would be an analysis of hysterectomies that were performed on women in 7 health plans found that 1 in 6 was inappropriate, didn't meet the recognized guidelines for that particular procedure. And then there are disparities. Although quality problems affect all populations, they may be most marked for members of ethnic and racial minority populations. So as an example of this, researchers at the University of Alabama, Birmingham looked at the use of clot busters for patients who had had a heart attack. And they found that while the evidence-based life-saving treatment was underutilized for all, so there was an underutilization issue overall, Black Medicare beneficiaries were significantly less likely than whites to receive this treatment. So by not following the guidelines, other issues came into play in decision-making in using different kinds of treatment. So there's a lot of evidence out there for why we would want to use evidence-based guidelines. And, you know, I suggest everybody kind of think about that and take a look at those studies that have been published. So I always like to find a quote that kind of drives home the point. And this was a challenging one. It's kind of hard when you Google quotes on use of evidence-based guidelines in healthcare. You don't come up with a lot. But I came up with 2 that I thought were very interesting. And the first one is pretty succinct. A wise man proportions his belief to the evidence. So it's not that people don't have the ability to make these political decisions on a case-by-case basis, or even the skill and expertise. However, belief needs to be proportioned to evidence. And when the evidence is staring you in the face, you need to maybe adjust belief in that regard. The second one is much more direct, and I really debated using it, but I frankly thought it really got to the heart of the matter and pretty succinctly. And this is a quote from Stephen Novella, who is a physician and a neurologist, who is a huge proponent of the use of evidence-based guidelines in care. And this is what he said: "There's nothing magical about science. It's simply a systematic way for carefully and thoroughly observing nature and using consistent logic to evaluate results. Which part of that do you disagree with? Do you disagree with being thorough, using careful observation, being systematic, or using consistent logic?" So it's a little bit of a snarky quote, if you will, but it gets to the point. Why wouldn't we use evidence-based guidelines? It's the basis of science. It's how medicine was taught in medical schools. It's based on science. And so we want to make sure that we are calling on that evidence as we create the care plans for our individual patients. So, next polling question, Valencia.
Certainly. And this one says, "For my practice and my specialty, I have sourced and implemented evidence-based guidelines. I have sourced but not implemented evidence-based guidelines. I have not looked for evidence-based guidelines." So we have about 45%, aiming for another 90% on this one.
No, we hit 90 last time. We should hit 90 every time today.
Sounds great. We're at 64%. Okay, looks like we're standing still at 64%, Cindy.
Go ahead.
71%, I have sourced and implemented evidence-based guidelines, and 29%, I have sourced but not implemented evidence-based guidelines.
And no one has not looked. That's fantastic. So, what we're proposing today is that we can use the Focus PDSA cycle. So our performance improvement methodology that all of you should be familiar with, because it's the methodology we've been teaching all along in our PTN project. But we can use that methodology to implement evidence-based guidelines. And the first thing that you need to do before you enter into that PDSA cycle is, of course, focus. Find, organize, clarify, understand, and select. And so this is the step at which you're looking for guidelines that you would want to use. And happily, a large percentage of you have already done this. So you already have in hand some guidelines that you might be looking to implement. So this first step, of course, would be to select the area for improving care based on your current performance. This is where your quality measures come into play. We've done a lot of work over the last few months looking at MIPS measures. Part of that was to comply with the QPP requirements, but part of it was really also to look at what was important to you and what measured the outcomes for your patients. And so you want to take a look at those quality measures and identify which ones are you doing well on and which ones are you not doing as well on, which ones provide for you an opportunity to improve. And that might be the first place to look for guidelines. So if diabetes is the issue, if hypertension is the issue, if depression screening is the issue, those are the things that you would like to look for your evidence-based guidelines on. Step 2, formulate a team, clinicians and support staff. Even though clinical decisions are clearly being made by the providers and your clinical staff, your support staff are exactly that. They support what your clinicians are doing or what you as a clinician are doing. And so you need to get input from everybody in implementing these, because you're going to need some help in hooking people up to services, in collecting all the information that you need, in really getting patients to open up about their condition and what they are and are not willing to do as part of a care plan. And then finally, find, evaluate, and select a guideline. So have that staff look at the guidelines that you went at. You found your quality measure. Let's say hypertension is what you wanted to look at. You found your evidence-based guidelines examples for that. Have your team look at it and evaluate which guideline makes sense for your practice. There are lots of guidelines out there. Some of them are going to be more complicated than others. You're going to have to adapt them to the staff and the situation surrounding your practice. And so that team of clinicians and support staff are the ones that are going to help you to do that, to get through the focus step. So where do you find these guidelines? On this slide, we provide several ideas of places where you can go to look for guidelines on the topic that you are interested in. The 3 databases at the top really are kind of the 3 primary databases where you really should be able to find as many guidelines as you want on pretty much any topic that you're looking for. The first one is PubMed, the second one is the Cochrane Library, and the third one is the National Guideline Clearinghouse. All of these are free. You can go in and do a search on any one of them. You can set the parameters of the time frame that you want the searches from. But if you go to any of these sites and you search on the topic that you want, you will return a number of guidelines that are out there for use. Another place where you can look is scientific journal listings. The one that we source that seem to be the easiest to use and provide the most results were the one that we have listed here. It's really a compendium of multiple scientific journals. And so if you go out there and look, what it's going to return for you are different guidelines that have been published in a multitude of different journals. And then other resources. For Delaware and PA, one of the places that we would like to direct you to is Quality Insights, which is the QuinnQIO organization in our state. They have a really nice website where if you go to this link for initiatives, it will allow you to look at the different programs that they have in place where not only do they have the guideline published, but they have tools out there that you can use. They have patient education tools. They have patient self-management tools. They have staff education tools and competencies. So there's a lot of things out there that you can use as part of your implementation plan if you use that site. These are by far not the only places you can look. Frankly, you can just go out and Google evidence-based guidelines for hypertension management, and you will return a whole bunch of evidence-based guidelines. We recommend these because these are databases that have been, vetted. We know that the research that's in there and the guidelines that are in there have been scientifically created and are good guidelines to follow. All right, so we focused. We found what we want to create or implement an evidence-based guideline on, and now we're going to start through our PDSA cycle. So we have our guideline. We're going to plan, and by plan, we're going to create a protocol specific to your practice. We're going to do by piloting that change, maybe at one office or with one provider. We're going to study. We're going to evaluate the evidence, the impact of that evidence-based guideline, both in terms of process measures, how well we followed the process, and outcome measures, how well our patients are doing now that we've implemented it. And then we're going to act. We're going to tweak and implement the protocol across the practice or all practice sites or providers. So those are the basic steps, and we're going to talk about each one of them individually. So P, our plan step. For the specific example of implementing an evidence-based guideline, these are some of the steps that you would walk through in the planning step. You've assembled your team of both clinicians and support staff. They need to be doing this collaboratively as a team. It's not the kind of thing that one person writes and then hands it to everybody else. You really want the input of all the members of your team so that you know you are assigning accountability for tasks for the right people. So the first step would be to write a protocol or procedure specific to your practice. Your guideline is going to be somewhat general. It might be very technical. You need to delineate it actually as a protocol and procedure with steps that your staff can follow. When you're doing that, you need to assign accountability for all the tasks. So take your team and their capabilities into account. If the evidence-based guideline says that it's important to have patients contacted once a week to check in on them and get their readings from their blood pressure, self-management, self-monitoring log, who can do that? Does that need to be a nurse? Can that be a medical assistant? Can it be someone at the front desk? If you have a team of 3 people, a receptionist, a provider, and a medical assistant, you're going to have to be creative sometimes about how you want to do these things. So you need to look at the protocol or the guideline. You need to develop how it's going to and write down how it's going to work for your practice. And most importantly, you have to assign accountability for all tasks. Keep in mind, if everyone is responsible, so if we just say we will do this and everyone's responsible for it, no one is responsible for it. So you have to assign primary responsibility and accountability for tasks. The next thing you're doing in this plan step is identifying how you'll measure your performance under your pilot. You want to make sure you look at both outcome and process measures. So not only did we provide this education to the patients each time, but how was their blood pressure then after that was done? State objectives and targets for your measures and predict results. So what are you trying to get to? We want to 100% of the time give the education out to people. And our predicted results after a month of a pilot is probably we're going to do it 75% of the time. So you want to predict both your objectives and targets and how you think you're going to get there. And then you want to create a detailed plan for implementation. So on this first slide is an example for a heart failure patient protocol. It's just a portion, a snapshot of what your practice's protocol or procedure might look like. So we put it in a table format so it's easy for people to read. They can easily find their responsibilities. We start with listing what's the intervention. So in this case, medication management is the intervention that this part of the protocol is detailing. There's a description of each step in that process. There's a responsible staff member assigned to that step, and then there's information about frequency. When are we going to do this? So if you look at this one, medication management, again, being our intervention, the first step is to ask patients to bring their actual medicine containers to their appointment. Who's responsible for that? The front office staff are responsible for that. And how frequently do we want them to do it? At the time of scheduling and when reminder calls are made. So that's when we want it to be done. What we want to be done is we want to remind people to bring in their med containers. The front office is going to do that, and they're going to do that when they schedule and make reminder calls to patients. The next step is to review all medications and reconcile to the EHR and confirm that the patient can afford their medications. So part of medication reconciliation in this step is not just reconciling the list in their EHR with the bottles that they bring in, but it's a conversation about whether or not they can afford their meds. You know, why don't you have that I see on your EHR that you're supposed to have this drug, but I don't see it in your bottles. Why don't you have it? Oh, I just forgot that one. Or, you know, that one costs $70 a month. I can't afford that one. I haven't filled that one. So who's responsible for that? Well, two people. The medical assistant starts it at every visit. She's going to do the reconciliation. And the nurse is going to do it when notified of transition of care, like discharges or ED visits. So in this practice, they have a nurse, and when someone gets discharged or transitions out of an ED visit and they get a notification of that, they're going to do that medication reconciliation, probably by phone with the patient. But there's different places and different people who do it at different times. The next step is to confirm and validate the medication reconciliation, address the discrepancies identified by the MA or the RN, and that's the physician's responsibility. And when does the physician do that? Well, they're going to do it at every visit and when notified of issues by the RN in any transition of care review. So first, the MA or the nurse goes over it with the patient, has a discussion, they document that. The physician has to be the one to follow up with any discrepancies that are found and have a conversation about that. If we go back to steps, prescribing the appropriate drug therapy, you know, we just go on and on with this. Of course, the physician is the one that's responsible to prescribe that drug therapy, and they do it at every visit. This policy actually lists the different kinds of drug therapy that could be used. I abbreviated it because we couldn't fit it all on one screen. But you want to get into as much detail in your plan, in your protocol, in your procedure as you can for your practice, and again, clearly delineate who is going to do each of these steps. So that's creating the protocol. The other thing that we're doing in the plan phase is creating our implementation plan for the pilot. And again, we can use a tool that's familiar to us from our PDSA toolkit, the Gantt chart. When you create a Gantt chart, what you do is you figure out, just kind of go through brainstorming, and this is adjustable and will be, you know, adapted for your practice. What is each task that we need to do? When are we going to do it? And who's the responsible party? So for this particular project, our tasks are to write the protocol, and we were going to do that in the first 2 weeks of January, and it's the heart failure team. So in the team meeting, we're actually going to write the protocol. Select process and outcome measures that we're going to use to measure how well we're doing, again, in the first 2 weeks of January, and the heart failure team has to pick those measures. We have to create patient education and self-management tools. Working on those the first 2 weeks of January, again, that's the heart failure team. So the next step then is to provide staff education to the nurses, the physicians, the nurses, the CNAs, the front office, on our guideline. On everything that we created up here, we're going to provide education to the staff on it. That's going to happen in the third week of January, and Dr. Jones and Mary Sue, the RN, we're going to take care of that. They were the responsible people. Then we needed to provide one-on-one staff training to Dr. Jones's team on their responsibilities in the new protocol. So this first one is overall staff education, basically telling the whole practice, here's what we're going to do. And we're going to do it by piloting it with Dr. Jones's team, and we're going to let you know how it goes once we do the pilot. In this step, providing that one-on-one training, this is really about talking to each of those people we designated in that protocol or plan and teaching them what they need to do. Again, who's responsible? Dr. Jones is going to teach the doctors, Mary Sue is going to teach the nurses, and Jose from the front office is going to teach the front office people what they need to do. Then we're going to conduct our pilot, and we're going to do that in the month of February. Who's going to do that? Dr. Jones's team is going to do the pilot. We're to do ongoing review of the process measures and communicate to Dr. Jones's team members and then adjust as necessary. So our process measures, how we said we were going to do that medication check, right? We were going to let people know they needed to bring their meds in, and then we were going to do that med reconciliation at the beginning of the visit. Maybe that's one of our process measures we picked. Did we do that each time? We want to follow that data, and throughout this pilot, don't wait till the end, but throughout the pilot, you want to share with the team, how are they doing? This is working, this isn't. Let's regroup. Maybe we need to tweak the way we decided we were going to do it. Maybe we need to reassign responsibility. But throughout this period of piloting, you're monitoring your process measures and you're giving real-time feedback to that pilot team. Again, who's responsible for that? Dr. Jones, Mary Sue, and Jose. They're keeping track of the information. Then we're going to review all the results, process and outcome measures, determine effectiveness, and finalize the protocol. And we're targeting the second week of March to do that. And that's the heart failure team. So that's where we take everything that we learned in this pilot, bring it back to the team. The team decides what worked, what didn't. Do we need to redo the pilot, or are we ready to finalize our protocol and then move back and start teaching one-on-one the other people in the practice how to do things? But this is a plan. This is how you create that plan. It's a simple thing to do. We have this tool in a generic format that we can give to any practice if you want to use that to create your plan of how you want to complete the implementation. All right, so we planned. Now we have to do, and so that's actually doing that pilot, right? It was what we had scheduled back here in February and March. And so what are we going to do during that pilot? First of all, we're going to ensure that all affected staff are educated and trained on that evidence-based guideline and the implementation plan and targets prior to starting. Make sure everybody knows what they're responsible for. Use teachback, whatever you need to do to make sure that the staff really understand what they're responsible for. Then we want to carry out that plan as a pilot. You could do that with one physician and their team. You could do it at one location. You could do it, if it's a small practice, for 1 quarter. If it's just, the physician, again, the physician, the receptionist, and 1 MA, you might want to try it for a quarter or for a month and see how it works, and that's your pilot. We want to measure performance under the pilot, and we want to be sure to track, again, both those outcomes and process measures. So our outcomes might be our hemoglobin A1Cs, our blood pressure, our BMI scores. Our processes might be measuring that education was provided, that referrals were made and completed, things like that. And we want to document problems encountered and solutions or changes made in the process. So when we're back here in our plan and we said while we are doing the pilot, we are concurrently monitoring performance. If we do make changes at that point, you want to make sure that you document that so that when we get back to the full team and we're going to finalize the protocol, we know what it is that we had to adjust and change. And that gives us a hint for our education going forward of the things we want to really focus on with the remaining staff that we need to train. So our do stage is actually doing the pilot. Now we're going to study. This is where we bring our information back to the team. We look at how the pilot worked, and we make decisions about how to move forward. So we evaluate the impact of the evidence-based guidelines. We compare outcome measures to prior state and predictions. We assess compliance with the evidence-based guidelines process measures. Did we really do what we said we were going to do? And then we review staff feedback, any problems encountered, and their solutions. So let's look at the process measures first. For this particular project, here's our heart failure project, what they decided that they wanted to look at was that medication reconciliation was completed at every visit and transition of care. They also wanted to measure that all patients were provided with their self-management tools. And they also wanted to see that all patients discharged from the hospital were seen within 48 hours. So every congestive heart failure patient that was discharged from acute care got an appointment in the office within 48 hours. Those were the 3 process measures they were going to measure. And if we look at what happened, the blue line is medication reconciliation. we started at about 80%, just a little lower than 80% as baseline. So we were already doing that pretty well. And we had a modest uptick in that in the end. So it's overall a trend line up to about 100%. But we had some issues in week 3. So probably there's a story around that. Something happened there at week 3 probably. We had a swap out in MA. Someone went on vacation and we had a replacement person and they weren't as aware of this new protocol. But overall, we've gone up. The next thing was that patients were provided with self-management tools. That's the red line. And we could see almost immediately a nice bump up in that. And we are doing excellent on that. 100% of the time now, we are giving people their self-management tools. The last thing we're looking at is people discharged from the hospital seen within 48 hours. Again, got a nice uptick. We've only gotten to about 80% on that one, so that might be something that we need to have further conversation on about, do we have the appointments available? Do we need to adjust how we are making those same day and short turnaround appointments available? But basically, we can see that we've had a lot of improvement here. Then we want to look at the outcome measures. So, because it's one thing to say, well, we did everything physically that we said we were going to do. It's quite another thing to understand, did we impact anything? Did anything change because of it? So this is 1 month, 2 months, 3 months. We're doing this one in months. The blue bar is the number of hospitalizations for heart failure patients. It went down slightly, was at about 5 in month 1. Looks like about 4 in 2, 3 in month 3. Number of ED visits for heart failure patients also went down slightly, just a little under 25 here. It's probably just a couple there. Percent reduction in hospitalizations for heart failure patients. So that's the green line. So yeah, the number only went down by a couple, but the percent decrease was pretty impressive, actually. It went down more than 30% over the course of this initiative. So this is a small practice. They're dealing with small numbers of patients. So they really did make an impactful change when you look at it as a percentage. If you look at the percent reduction in ED visits, that was impacted a little less, right? So that under 10% change. That's not as much of a change on that line. So we aren't necessarily keeping people out of the ED as much as we are keeping people out of being hospitalized. So that's something that the team would want to think about. What else do we need to do? Do we need to think about our office hours? Is the problem with this ED issue that they're feeling sick in the middle of the night and they don't have any other option, or they let it go and they didn't call until late in the day and now they can't get an appointment and so they end up going to the ED because they can't get in to see us? Is there something we can do to open up appointments for people to be able to get in off hours? Can we make some kind of an arrangement with an urgent care that we work with on the protocol so we know they're going to do the things we want them to do, and we direct people that way? So sometimes you collect this data and it creates other questions that you need to answer. And that's why it's a circular process and you just keep improving. So that's study. Finally, act. We use the pilot results to fine-tune the protocol. We create a detailed plan to implement the evidence-based guidelines to the remainder of the practice. So that's down here, similar to what we did before. We continue to monitor our measures. We monitor outcomes as long as the quality measure is important to your practice. So quality outcome measures, you don't stop monitoring. If it's important to your practice, you're going to keep monitoring those measures. Process measures, you track until compliance is at or near 100%, and then you spot check it if your outcome measures fluctuate downward. So process measures don't need to be tracked forever. And that's an important thing to think about, because process measures are sometimes the things that are more difficult to track when you're doing these projects, because they require somebody to actually count and keep track of something, make tick marks to say how many times they did something, or manually keep track of things. And if you add a bunch of things to your staff that they have to manually keep track of, you will not get good data. So if they know they only have to do it long enough to show that we do it 100% of the time, and then we'll spot check it if our outcomes start to go down, they're going to be much more amenable to doing something for a short period of time then thinking for the rest of their lives they have to keep track of how many phone calls they had today and how many of those patients they got in today for a visit. We'll talk in a little bit about using your EHR to do some of this work for you, but that is just something to keep in mind. You don't have to track process measures for the rest of your life. You just have to track them till you can show that you're stable, and then you spot check them when you have a downward fluctuation in outcomes. So this chart at the bottom is really just a continuation of that Gantt chart, and now it's about providing the one-on-one training to the rest of the doctors, Dr. Miller's and Dr. Chin's team, on their responsibilities in the new protocol, and then implement them, ongoing review of the process measures with those teams, check the outcomes routinely using EHR dashboard and quality monitoring reports, and discuss on any negative changes in outcomes. So it's something that you want to revisit every once in a while to make sure you're still on track and you're still following what you wanted to do. So that's basically the PDSA cycle used to implement an evidence-based guideline. Find the guideline, put your team together, create the protocol that mirrors that guideline, but that works for your practice with your team, being sure to assign accountability. These are some important things to remember as you're creating your protocol and your plan for your practice. Be sure to include staff education and competency review of the evidence-based guideline for all affected staff. Education is so important, and actually assessing competency, using teach-back, making people show you that they know what they're supposed to do and they understand what they're supposed to do, and not just saying, okay, I taught them once, they should just know it. You have to stay on top of that and make sure that your people understand what they're being asked to do. After implementation, continue to monitor your outcomes to ensure sustained results. So those outcome measures, monitoring them is important. Using products and tools already distilled and prepackaged by professional groups. For example, the AMA, the ACP, nursing societies, the QuINQ-IOs, their sites will have patient self-management tools, patient education tools, staff education tools that are ready-made for you to use out there. When you're doing your search for your evidence-based guidelines, look for those kinds of guidelines that have those prepackaged, ready-to-use tools available for you. Use a change champion in the organization who can address potential implementation challenges can be very beneficial. It's really important in this area. You know, a lot of the projects we work on are more operational in nature. We're not really talking about changing or adjusting clinical practice, but this would not be one of those. I mean, this is clinical practice guidelines. It's an evidence-based guideline. And so we really need a clinician, a provider, to be the champion of these projects and to really own it and to really give voice to that, to the staff, so that they understand this isn't just another passing fad. This is something that's very important to our providers. And then finally, always use a multidisciplinary implementation team to assist in the practical aspects of embedding these innovations into your processes. This is critical. Clinicians, providers cannot do this alone. There's much too much work. There's far too many loose ends. There's a lot, as you saw from the example that we went through, there's a lot of pieces that need to be done by a lot of people. So make sure you're including those people or representatives of those people in your development teams as you develop the evidence-based guideline protocols for your practice. I'll say one other thing about that. If you have a large practice, you can't include everybody. You can't have every doctor and every nurse and every MA in your practice when you have a 15-provider practice on your evidence-based guideline implementation team. You've got to pick one or two representatives of each of those categories to serve as the voice for those people. And then those team members are responsible to be talking with and going back and taking information back to their fellow coworkers to expand the input of information. But if you try to do this with a meeting with 50 people in it, it's just not going to work. You'll never get anywhere. So definitely create a team of representatives. Let that team hash out the details. Where you get the input from the rest of the staff is from the conversations they have with their coworkers and peers, and from the pilot. As you roll out the pilot and then roll it out into practice, you have to continually take that feedback back from different staff members. All right. Education, execution, patient and family engagement. Engaging patients and families is going to be critical to any pathway you pick. That isn't even a factor of evidence-based guidelines. That's just a fact of life. We see our patients, maybe 4 times a year for 15 to 30 minutes if you're lucky each. They spend 365 days, 24/7 with themselves. So very little that we create in way of a treatment plan is something that you're going to impact with just those visits. They have to be invested in their care. They have to have some accountability and responsibility for that care plan. And it's probably the most difficult thing that we do. I speak not as a clinician, but as a patient. I can assure you I make my PCP crazy because I'm not always that good about following that care plan that she has set up for me. So we have conversations about what can I and what am I willing to do and what can I do and what can't I do. I'm not going to say that I'm going to lose 40 pounds and go to the gym twice a week because that's not going to happen. But I could probably lose 10 pounds and I definitely could walk 2 times a week. So, you have to engage your patients in where they're at. Like we need to meet them where they are. So engaging them. Creating or sourcing patient education tools that they can understand, really critically look at the documents that you're giving to people for education. Can they really understand them? Or are we talking way over their head? I always say that medical assistants, this is like a great role or area for medical assistants. Our medical assistants are clearly not doctors. They're medical assistants. They have some level of training and experience and exposure to medical terminology. But generally speaking, they far more closely represent the general public than physicians do, or even than nurses do. Can they understand the documents? If they can't understand what they're trying to give to patients to teach them with, it's probably a little bit over the patient's head. So we want to really think about that. Tools they can understand. Create or source patient self-management tools they can understand. So education they can understand, tools they can understand. To the left, to the right, on my other left, you can see an example of a patient self-management tool. This comes from the eBright ACO, who is one of the partners we work with in this area. As the PTN, we don't serve the ACO practices, but we do serve the specialty practices that work along with the ACOs, and so we frequently share information back and forth. They've created some lovely self-management tools that show people basically what they need to do every day. When they know they're good, this means you're all clear. If any of these things are happening, it's caution, you're in a warning zone. If any of these things are happening, take action now because there's a big problem. So look for those kind of tools. Source those kind of tools from your partner practices, your friends in the community, the internet, and the sites that we provided before. Provide options for feedback between visits. The patient portal, care coordinators, or follow-up calls. Not everybody can afford to have a care coordinator in their practice. A patient portal can be a really effective and low-cost solution to allowing patients to contact you in between visits when they just have a question, or when you just want to check in with them with a question. You'd be amazed at how many people really do use email. Yeah, a lot of people don't. So this is not a solution for them, but a lot of people do. And so we want to make sure that we're using whatever we have available to us to get feedback from patients in between visits. We want to give patients an informed choice in their treatment plan at every stage, and we want to document their involvement. So really write down those conversations that you have with your patients about what they can and can't do, what they are and are not willing to do, so that we really can see that that treatment plan is built around their needs and preferences. And then finally, can't say this one enough, use teach-back at every level of patient interaction to ensure patients are fully aware of and can carry out their responsibilities. Teach back is simply asking patients to repeat back to you what you have asked them to do. So teach back is not the doctor tells the patient, I want you to take your blood pressure every day and record it in this log. And then we're going to do a weekly phone call to follow up with you. Okay, that's an instruction. Teach back would then be to say, now, just so we make sure that we're on the same page, what do I want you to do with your blood pressure readings every day? They should be able to say back to you, write them on this log. And then you can say, and then how will I know about that information? You're going to call me once a week. The medical assistant's going to call me once a week. If they can't answer those two questions in their own words, they didn't really understand what they were told. And so we know then that we need to reinforce that. And that can be done by the physician. That can be done by a nurse if you have that ability within your practice. It can be done by the medical assistant. If the physician documents in the care plan that the patient has been asked to take their blood pressure daily, put it in the log, and we will call them once a week to monitor, the MA should be able to read that in the visit summary. And as part of the checkout process, again, say to the patient, I see here that Dr. Jones has asked for you to do a blood pressure log. Can you tell me, what are you going to do? How are you going to do that? Again, they should be able to answer you. If they can't, that's another teaching opportunity. Okay, here's what we're going to want you to do. Did he give you a log? Okay, let's look at it together. We want you to take your blood pressure every day. You're going to write it on this line, and then you're going to get a phone call on Friday. And we're going to check and see how your blood pressures were for the week. That's just an example of how and when you should use teach back. But it is so important that you do it at every level of the visit. Statistics show that people only remember 20% of what they're told in the doctor's office. 20%. So if you're sending people out and they only heard 20% of what you told them, they're probably not going to achieve the outcome that you wanted them to achieve. Teach back is vitally important to fight that. Okay, now from education to execution, hard wiring. There are some things that you can try to do with your EHR to help you implement these evidence-based guidelines. One is standard order sets, not standing order sets. So the standing order, which is nobody likes to talk about anymore, was what we did in the past where you automatically did X, Y, and Z when you admitted a patient to a hospital, or they were standing orders. It happened to everyone. There was no thought process. Standard order sets is where you put into your EHR all the possible things that you could order for a patient with a certain diagnosis, so it might drive off of your problem list. And you still have to pick and actively order the things that you want to happen, but it does serve as a bit of a checklist and reminder of the things that are available and appropriate to do for that patient. So standard order sets are a menu of possible appropriate options that are triggered by your problem list. You pick the ones that are appropriate and in line with the patient's goals. It's not standing, it's standard. Another thing that EHRs can do sometimes are care gap flags. And so these are things to look into with your EHR and to talk to your vendor about, or to do a little deep dive and a little investigation yourself. Can your EHR flag patients who have gaps in their protocol or care? So if you have a protocol that says you want to see your diabetic patients whose A1C is over 9 every 90 days, and you have somebody whose the last A1C that you have recorded in your EHR is over 9, and they haven't been in for 90 days and they don't have an appointment on the calendar, can you flag that somehow so that you can reach out to them and schedule that appointment? So look into that. What possibilities do you have in your EHR to flag patients with gaps of care? Can your EHR flag patients whose outcome measures are out of range? So same kind of thing. The lab result is wrong. It is not where you want it to be. So now I see that. Can you flag that patient so that I know to reach out to them? Can your EHR integrate into your schedule these flags so that when patients are coming in and they're on the schedule, a flag appears next to them that says, kind of an alert, alert, The last A1C we have on this patient is 11, okay? So now you know that, and it's telling you right away you need to address that in the visit. Or a gap in care, a flag that says, alert, this person's coming in today and they haven't had their annual mammogram. You haven't ordered an annual mammogram for them. So that reminds you to do that on that day. So care gap flags and your ability of your EHR to do that is something definitely to look into. Not all of them will be able to, but some of them will. Post-visit summaries. Ensure that the plan of care is front and center, and have your checkout staff review and use the plan and review the plan using TeachBack. So your post-visit summaries, you know, a lot of times they're in this order of, okay, here's my problem list, here's my assessment, and somewhere down at the bottom on page 2 or 3 after the, you know, really long medication list is the plan. Think about moving your plan of care to the top of your post-visit summaries, because frankly, that's what everybody's looking for anyway. That's what the doctor who referred them to you is looking for. That's what the patient's looking for. So there's no law that says the plan of care has to be at the end of the post-visit summary. Put it at the beginning. And have your checkout process include your checkout staff reviewing that plan of care and using TeachBack to ask the patient, I see that Dr. Jones changed your prescription for Coumadin. Can you tell me what he changed? What did he ask you to do? Hopefully they can tell you. Hopefully you won't have to review it. But if they don't, if they say, yeah, he said something about that, but I don't remember, there's your opportunity to teach again, to say, all right, well, let's look at your care plan here. Right here, it tells you what you need to do. So if you forget, no, it's right here in your care plan. So post-visit summaries. Know your workflows. Do you know how your EHR captures and processes your outcome measures? Do you really know which fields you need to check off, fill in, complete in order to capture data on your patient's outcomes? All EHRs include some kind of instructions to this regard. Some people call them tip sheets, some people call them workflows. Whatever your EHR calls them, make sure you are familiar with those and that you know that you and your staff are documenting correctly in order to capture your outcome data. And then finally, identify ways to streamline those so that you can get accurate data capture. All right, so requests and offers, and we're rounding up here. Here's our requests and offers from your PTN. We're requesting that each of our member practices commit to implementing at least one evidence-based guideline in 2018. That guideline should be aimed at improving one of your selected quality outcome measures. So one of your MIPS measures that you've already picked. Let's look at them. Let's figure out which one we have the most opportunity for, and let's find some evidence-based guidelines to implement that will affect and impact that measure. Our offer to you is that we will provide additional assistance to you on the selection and implementation of these guidelines. And the first thing that we're going to do in that regard is provide 2 additional webinars in this series. On May 31st, we're going to have a webinar on hypertension and diabetes evidence-based guidelines, and Quality Insights, the Quinn QIO from Delaware, is going to do that for us. They're going to present that. They have 2 very robust programs around evidence-based guidelines in these 2 areas. And even if you don't reside or practice in the state of Delaware, their tools are all available online. And it's something that you could work with your practice advisor to implement without their assistance. If you are in Delaware, you actually could enroll and get their assistance to help you to implement these programs. The next webinar that we're going to do on the topic is in June. We haven't settled on the date yet, but it, of course, will be a Thursday. And that's going to be on selecting evidence-based guidelines for core quality measures. So the things that we're looking at right now are congestive heart failure, BMI. I don't remember if we stuck with depression screening. We have 4 of them, and I really should have been more prepared to say exactly what they were on this call, but we're going to have a second one that's going to go into additional guidelines on the other core measures that we're looking at. We will provide you with project assistance. So your practice advisor will continue to provide on-site, one-on-one, ongoing assistance to coordinate and carry out your implementation plan using the PDSA methodologies. So we're not throwing you out there and leaving you out there alone. We're going to provide you with some ways to find these guidelines, and most importantly, some assistance to help you facilitate the implementation of them. So here's our last polling question.
Okay, great. And based on today's presentation, my practice will identify and implement one evidence-based guideline in 2018. My practice is unsure if we can implement one evidence-based guideline in 2018. And my practice does not plan to implement one evidence-based guideline in 2018. So we have about 25% that has voted, and it looks like we have 100% that will identify and implement at least one evidence-based guideline in 2018.
Okay. I know we're moving along rather quickly now, but we're going to run out of time if we don't. So there's one more follow-up question to that. So if you'd like to launch that one, Valencia.
Yes, and you all have multiple options for this one. I would like information on specific evidence-based guideline related to diabetes, hypertension, heart disease, obesity, and other. So you have multiple options on this one, so please feel free to utilize that.
And as it says there, please do put a comment. If you click off other, because there is something specific you're interested in, if you would just make a note in the chat box of the topic, that would be great.
Looks like we have about 42% that have voted, and 80% would like information on diabetes, 80% on heart disease, 100% for hypertension, and 40% on obesity.
Okay. That will be very helpful to us as we pull together that information. I did want to say that our medical director, Dr. Ed Sobel, as well as Blake Williamson from 2.0 Healthcare, Dr. Blake Williamson, and Colleen Davis from 2.0 Healthcare, who is a physician assistant, are diligently working on pulling together a lot of resources on these evidence-based guidelines for that June session. So I think it's going to end up being a really good session. So any other questions out there? I know we are right at the top of the hour. My last quote was, "I never learn anything talking. I only learn when I ask questions." So if you have any, please, by all means, put them out there or in the chat or in the question box.
And I don't see that we have any as of right now, Cindy.
Okay, we'll just take a couple more minutes. We'll wait to see if anybody puts anything in, and I'll point out a couple of other things. Please download the slides out of the handouts box. These will also be sent out in a blast email follow up to this session. References for all of the information that we had in here are listed at the back, so you can find those actual references. And of course, our contact information for our team members is available in the last slide.
Okay, great, Cindy. Thank you for that excellent presentation and all of those sources and information that you gave us as a reference. And again, we'll keep the line open for a couple minutes so everyone can download today's presentation. And we thank you all for participating.
Thanks again, guys.